Good morning. Thank you, Chairman, for the kind words. And I would like to thank the organizing committee for the invitation, as well as provide the opportunity to present my topic, sleep apnea in older persons. And sleep, as you know, that is a complex and dynamic process involving altered consciousness with reduced muscle and sensory activity. Whereas apnea, this is an episode of complete cessation of breathing, which is lasting at least 10 seconds. There are different types of sleep apnea: obstructive, central, and mixed. Obstructive means when there is apnea occurs during sleep caused by the obstruction of the upper airway despite ongoing respiratory effort. Whereas central sleep apnea is episodes of apnea during the sleep in the absence of respiratory effort. And when there is a sleep, OSA, the obstructive sleep apnea, with excessive daytime sleepiness and fatigue, we call it OSA syndrome. And a little bit of the in-taxes which we used in sleep study. Hypopnea means there's a partial decrement in airflow. And we use the index, apnea hypopnea index, which can be measured during sleep study as for the definition of different types or grades of sleep apnea as defined by American Academy of Sleep Medicine. Mild means 5 to 15 of AHI index, whereas 15 to 30 we call it moderate, and if it is above 30 AHI, we call it severe OSA. And what are the risk factors of OSA? Mainly as age, when it's more than 40, and comes to gender, mainly males as well as postmenopausal females are prone to get it. And another high risk factor which we come across is obesity, when there's BMI is more than 30 kilogram per meter square, as well as upper airway abnormalities. And when there is neck circumference more than 17 inches in males and 16 inches in females, and family history, and the habits, mainly smoking and alcohol usage. These are the main risk factors for obstructive sleep apnea. And as I mentioned to you, the prevalence of OSAs is increasing in older adults. As you can see, the range is from 13 to 32. The major sites of obstruction, mainly in the nose and retropalatal, that means posterior to the palate, as well as retrolingual, that means posterior to the tongue. These are the areas in the upper airway main we see the sites of obstruction. What's happening in normal breathing as the air enters through the nose, enters to the pharynx, to larynx, to trachea and lungs. Whereas in snoring, as air goes through, there is partial obstruction. So what happens is this throat tissue vibrates. So that's what causing this hard sound snoring. Whereas in OSA, as you can see, there's a complete obstruction which causes cessation or stoppage of breathing. What's happening in sleep apnea, basically sleep? When you sleep, as I mentioned, the airway collapses. What that causes apnea and lead on to hypoxia and hypercapnia. There will be a ventilatory effort. When there is a ventilatory effort, it causes arousal from the sleep, which in turn increases the pharyngeal muscle activity, which opens up the airway. Once airway is opened, that will correct the hypoxia and hypercapnia. Patient falls back to sleep. And this cycle continues. That's what's happening to the sleep in these patients. So what are the effects of the sleep apnea? Yes, you can see it affects all the major systems. Say start from cardiology, endocrine, and so on. So you can see from these slides that it affects in, say, cardiovascular system. It causes arrhythmias, hypertension, myocardial infarction, heart failure. Whereas in endocrine, patients are diabetic, they will have increased insulin resistance. And in psychiatry, basically in central nervous system, and psychiatry causes depression, mood swings, memory loss, at high risk of stroke and migraine, and generalized fatigue. And in genitourinary, you can see impotence, lack of sex drive, and in general, it causes family harmony, affects the family harmony, working competency, interpersonal problems. Along with that, there are public health problems. It's increased traffic and workplace accidents. And respiratory, it worsens asthma, COPD, and cough and pneumonia. Thus, you can see the whole general, all the systems in the body being affected by obstructive sleep apnea. What are the symptoms? These are symptoms mainly you feel excessive daytime sleepiness, and along with certain patients does have loud snoring. And the bed partner can tell you that has witnessed episodes of stop breathing during the sleep, as well as there are abrupt awakenings. Certain patients can tell you that accompanied by gasping or choking. And certain people, most of the days, are awakening with a dry mouth or sore throat. There will be morning headache and difficulty in concentrating during this daytime work, decreased libido. So how do you clinically evaluate these patients? We will take a detailed history as well as physical examination, and we do have something called the procedure called flexible nasopharyngoscope, as you can see, which can introduce to the nose, to the pharynx, to the lungs. We can see the upper airway obstruction actually. Certain patients cannot tolerate. In such patients, we might have to do drug-induced sleep endoscopy. And as you know, sleep study, otherwise called PSG, polysomnography, that's a gold standard test to detect obstructive sleep apnea. What is this sleep study? There are different levels, but most commonly what we use is a level 1 and level 3. Level 1 sleep study means it's the overnight sleep testing. It's done in a sleep laboratory with a healthcare professional in attendance, basically, and is diagnosed if all the types of sleep disordered breathing can be diagnosed, but it contains multi-channel 7 to 16, whereas level 3 studies is a portable home sleep study, and it should be done in patients with a clinically moderate to severe OSA without significant comorbidities. It contains only 3 to 4 channels, which measures SpO2, respiratory effort, and heart rate. As you can see here, this is a polysomnography whereby you can see all the multiple channels from EEG, UG, NG, oronasal flow, and snoring, you can ECG, all those been measured. Whereas level 3 basically is a portable, easy to use, and is cost effective and convenient. It is here that sleep apnea has been tested in the comfort of their own bedroom, where testing in their own environment most of the time help their experience, right? And along with that, there are various questions, screening questions as available, like stop bank, which is a validated screening tool, as well as Epworth sleepiness scale. The stop bank question is like this. You have actually snoring, that's what indicates snoring, tired, observed sleep apnea, the observed apnea, and the blood pressure, and so on. In this question, if it gets more than 3, that indicates intermediate risk. If it is more than 5S, that indicates high risk. Whereas in Epworth sleepiness scale, which mainly measures the daytime sleepiness, if the total score is more than 10, that means it's got intermediate risk, and more than 13 is high risk. So how do you manage OSA? It needs a multifaceted approach where proper diagnosis and treatment definitely improves the quality of life and decreases the morbidity and mortality. And most important step in the management is patient education. We should explain the whole scenario to the patient. And I need to tell you, the core component of treatment is positive airway pressure. I will explain to you later. Along with that, you need to do lifestyle or behavioral changes. Definitely, it's going to help the patients. And losing weight by dietary modification, regular exercise, avoid use of alcohol and sedatives, avoid cigarette smoking, and adjust sleep position is really going to benefit. Along with that, there are other treatment options, oral appliances and surgery. And as you can see, there are various oral appliances for the tongue retaining mandibular reposition. Surgery which depends on the level of obstruction. Say, for example, if it is the nose, if there is a turbinate hypertrophy or subtle deviation, or is it to long uvula, or if it is huge tonsils, depends on the level of obstruction. do the surgical options. And again, I would to stress the point is that the core component of the treatment is always of a use of positive airway pressure. That means positive air. Most common PEP we are using is a CPAP. That means continuous positive airway pressure. There are other types available, BiPAP and APAP, but most common we use is a CPAP. Continuous positive air pressure. It's a gold standard treatment for moderate to severe. It is something like that. Actually, it's a pneumatic splint which prevents the upper airway collapse. And the benefits, it improves the quality of life. It lowers the blood pressure, rates of arrhythmia and stroke, improve the left ventricular ejection fraction in patients with heart failure, improve the rates of fatal and non-fatal cardiovascular events in short. It reduces the reflux symptoms, and patients will have better concentration and memory. And in diabetic patients, it improves the insulin sensitivity. But that CPAP does have some issues, especially some patients find it can be challenging and hard to adapt to daily use. So you really need to analyze the problem and sort it out. The common issues which we come across is the nocturnal arousals, which needs optimal pressure setting. And there are patients complaining about nasal irritation, which needs proper mask, dryness of mouth, if that is, we adjust the humidifier. Aerophagia, then you need to adjust the pressure, as well as mask dropping, you might have to adjust the mask. So these issues can be sorted out. And other treatment options, such as I mentioned earlier, like oral appliances and surgery. Oral appliances, the indication is mild to moderate OSA if the patient is unable to adjust using PAP machine. There are mainly the two types, mandibular advancement, tongue retaining devices. And another option is surgery. The option is it should be indicated only in failed, unsuitable, and intolerant for the CPAP therapy. Selected patients with anatomical problems has to be then only undergo the surgical indication. And the most important point is that patient needs counseling prior to surgery. Various procedures, as I mentioned earlier, it can be if there's a block in the nasal or if in the oral cavity tonsils. And if really patients severe heart failure, sometimes tracheostomy, morbidly obese patients might need bariatric surgery. So, but comprehensive patient counseling is very important in surgical options. So, in short, in conclusion, I would like to say that sleep problems in late life are often unrecognized, and OSA is the most common sleep disorders which we come across, and it causes significant health consequences if left untreated. It affects all the body system, so you need professional help to identify obstructive sleep apnea. And it is easy to diagnose and recommend treatment options. As I mentioned to you, we can do the sleep study, which is diagnostic standard, and CPAP, continuous positive airway pressure, is effective and remains the first line treatment for obstructive sleep apnea. Along with that, patient education and lifestyle changes can reduce the severity of OSA. Thank you for your attention.